Welcome everybody. Tonight we're going to talk about the ever-going problem of synthetics. I know we talk about synthetics a lot here. We're going to talk about synthetics. We're going to talk about meth. Mainly what we're going to talk about tonight is why when these people start taking synthetics and start getting on meth, why they get addicted to it. What causes the body to say, I want more, I want more. And so we're going to discuss that a little bit tonight. I've got a couple of cases that we're going to look at. Been visiting with Dr. Troutman today about these cases. Hopefully he can give us a little bit of insight on it. Everybody knows what we use for our synthetic patients. Sometimes it works, sometimes it doesn't work so well. These cases tonight, you're going to see one that worked very well, and you're going to see one that didn't work so well. So we'll get started with that. Please silence all your cell phones and things like that if you haven't. If anybody has a question during any of this, say the question loud enough so that the microphone can pick it up, so that whenever everybody watches the video, they can hear what your question is. All right, this is one contact hour for state is medical, and for NREMT, 1 hour of psychiatric medicine that you have to have in order to renew. All right, let's get started. Welcome to my other world. Doctor's Guide to Excited Delirium. All right, so today we're going to look at understand what defines delirium and its subset, excited delirium. That's what we are mainly keying on, is excited delirium. Learn about the signs and symptoms of excited delirium, pathophysiology behind the brain's reward pathway. We'll talk about that here in just a little bit, the reward pathway of this is what gets these people hooked on these meds or these drugs. Explore the effects of methamphetamines on the neuronal system and examine the difference between synthetic cannabinoids and Cathinones. So, what is delirium? Alright, so it's a broad term that we use. Some people, they go from normal to just out of control, crazy acting, kind of Superman strength, things like that. What is normal for that person? And what is causing that delirium? Is it a medical condition? Is it something that they have ingested, narcotic-wise? Or, what's causing this? Something we see pretty frequently, I like little Kim's, little squirrel, spider thing, a little confused there. Brief period confusion is not delirium. So if somebody just says, oh, I got confused, I lost track for a few minutes, that's not delirium. That's not what we're looking at. This is something that's, longer. They are more aggressive acting. Sometimes disturbances in consciousness, cognitive changes, memory impairment, can last from hours to days, and sometimes it fluctuates, it just depends. Can we fix it? Well, depends on what causes the delirium. Over here you have CVA. Well, if we're dealing with the CVA, we know some signs and symptoms of CVA. We can deal with, do we have a positive Cincinnati stroke scale? The patient may not be acting correct. It may be they're having a stroke, maybe having a bleed. Hypoxia. You've all seen those patients that are, extremely hypoxic, and they're not acting appropriate, and you think that they may be on some kind of drug or some synthetic or something. And no, it's because they can't breathe, or they need some oxygen. You all know what happens to the body when it starts getting oxygen deprived. It can do strange things. It wants oxygen. Infection. Infection can cause people to do really strange things. We see people, you go to a house and they say, I saw Granny last year, she's not acting anything like she normally does. She's, when you ask her if she wants to go to the hospital, she kind of pulls away from you. She kind of wants to fight you a little bit. You get to the hospital, it's just an infection. Maybe a urinary tract infection. Severe pain. We started with the extrication with the 0.5 milligrams per kilogram of ketamine, because we saw these people trapped inside these cars. It was taking us forever to get them cut out. They were screaming and hollering, grabbing at you, and we started using ketamine to kind of make them relax a little bit. Dehydration can do that. Hypoglycemia, we've all seen those patients that, they go from 1 minute to, they're talking crazy, saying things that you never would expect somebody to say. You check their blood sugar's low, you treat them, and then they turn around and, well, when did you get here? And they start asking you questions. Medication, drug effects, physical or emotional stress, and there's a lot of others. Some of the other ones in here, like hypovolemia from trauma. Hypovolemia patients, they're not perfusing their brain well, so they get a little crazy. Delirium has an escape clause. Well, the biggest thing on this, remember, delirium, excited delirium, it's not chronic. People can't say that, well, this has been going on for about a month. They've been acting this way. Well, that's not delirium. That's not something that has been going on for a month, 2 months. In delirium, you're looking at somebody that starts immediately, and it's an acute problem. They go from acting completely normal to trying to pick up a vehicle and move it around, or they're ripping their clothes off and running up and down the streets. That's acute. It happens suddenly. Not every person is alike. As you're going to see in the reports that we have. I was telling you, one of the patients did the ketamine. It worked great for them. The other one, it didn't work so well. So everybody's different. Talking to Kim, about some of the stuff. People who are on like your ADH medicines, like Ritalin. Somebody who's on Ritalin, they may act totally different off of a couple hits of a synthetic or meth compared to someone who's not on any Ritalin, simply for the fact of the dopamine response. We'll talk about that here in just a little bit. Cancer, liver failure. How many of y'all seen those liver patients that their ammonia levels are through the roof? And you don't want to mess with them because they'll beat you half to death. And it's all because their ammonia levels are high. Alcohol, drug dependence, depression, or psychiatric disorders, dementia, brain tumors, things like that. So what is excited delirium? It's a subset of delirium, and it may be used to describe patients displaying altered mental status with severe agitation. Remember, some of these right here are what we kind of talked about in when we put in ketamine for combativeness, hyper-aggressive with bizarre behavior. Some of these are those key terms that you need to put in your documentation to justify why you used and why you gave somebody ketamine. Combative. How are they combative? How many people is it taking to hold that one person down? Can I hold a person down that's being combative, or does it take 4 or 5 of us to hold that person down? That's a big difference. Hyperthermia, the skin is hot to touch. I really do believe that we do a really good job here of taking care of our patients. And hyperthermia is probably the biggest killer for these people who are in this excited delirium state. And whether we go on somebody 4 or 5 times that did the drug, they go AMA, they go out and buy some more, they do the same thing, you run on them again, it's their fault that they did that, but we are still the patient advocate, and we're going to take care of that patient. We can't just let them die. And so that's why you need to be So who gets it and who doesn't? Not every person is alike. They all develop delirium different. Some people may kind of, everybody, we've always talked about everybody gets affected by medications and drugs the same way. So if one person takes a hit off this, they may be perfectly fine. Another person comes along, take a hit off of it, they're not going to be perfectly fine. They may freak out, start having seizures, start trying to kill everybody around. And we're going to see that here in just a few minutes in a video that we found. That was pretty neat. Advanced age or sensory impairment has a big difference. Chronic diseases, again, the liver failure, people who can't, once they start doing these drugs, they can't break it down to get rid of it. If they're already depressed, or if they have psychiatric disorders to begin with, it doesn't really help that they're taking something that's going to mess them up even more. So this little place right here, this is the McLean Asylum, picture from 1845. Dr. Luther Bell, he was the one that kind of started the term of excited delirium. This is what these people have. This is what he believed, that 75% of those who were suffering from it took their own life or died in some way, shape, form, or fashion once they started diagnosed with the Bell's mania. So it's been around for a long time, but the question is, a lot of people don't believe that it's actually true. I know talking to Darla about the billing portion of it, they don't really have a ICD-10 code that says excited delirium on it, but there are other codes that you can put in there for it.
It's hard to believe because they have them for being pecked by chickens or hit by airplanes.
I
like the hit by airplane second encounter.
Yeah, not only did it happen once, it happened twice. So excited delirium, is it real? I mean, how many of us have been on a call where we see somebody acting like this? Some of the people we run on, when we get there, there's 3 or 4 police officers trying to hold them down. There may be 3 or 4 first responders trying to hold them down. They are out of control. And a lot of these medicines that they're taking, or these drugs that they're taking this stuff and getting addicted to it, and then they just keep doing it. That's what these people who are selling this stuff, that's what they want. They want these people to get addicted to it. And if left medically untreated, the risk of death is very real. How many people have gone to the ER and have coded later? A lot of that we found, we felt that was because of the Versed we were using. Was it? Don't know. I know that I can think of, we haven't had anybody code at the hospital after given ketamine. I know we've had a few with some other benzos. So these people are sick and they do need help, and we have to take care of them. Like I said, it's not an official ICD-10 code yet. I bet you it will be soon, right along with getting hit by the airplane twice. So let's talk about the reward pathway. Delirium has many causes. Like we talked about the hypoglycemia, hypoxia, and head injuries and stuff like that. But delirium is also caused by body function needs of what you're putting into it. And that's what we're going to look at here in just a second. How these people take these drugs and they get rewarded. Their body gets rewarded for taking the drugs, and they get dependent on it. It's almost like you get rewarded, or you get that reward feeling whenever you eat a donut, or you buy yourself a new car. If you win the lottery, your body's like, holy cow, that's the greatest feeling ever. And it's the same concept, but you're not feeding it something. It's just something that you get. Well, dopamine is the primary transmitter of the reward pathway, affecting motivation, the experience of pleasure, the memory of it, and the motor function. So when you start talking about dopamine with the body, dopamine is the biggest contributor when people take meth, or when they get on the synthetics. When you look at this slide right here, dopamine's released from the brain deep inside. And when you think about it, it's not the same dopamine that we have on the truck. If I eat a cookie, that portion of the brain says, wow, these are the best cookies ever. I love these cookies. they're so good, I'm just going to take another bite. So you start taking another bite, and you eat another cookie, and next thing you know, cookies, you now have 100% of my entire attention. So the brain is telling itself, I love what I'm taking. And this portion of the brain says, I'm going to remember where I got these cookies. So what is that? You basically, when you're dealing with narcotics or drugs, your brain says, that's one of the best drug dealers on the street. I'll never forget him. He's my best good friend. And so the brain starts releasing this dopamine, and it starts telling the brain how it can remember who that is and where they're at. It's released and taken upon the neurons constantly. Meth. Let's look at meth here. This is an illustration of two neurons communicating with each other that have not introduced meth into it yet. You have your dopamine as your blue, and your dopamine receptors as the purple. So in normal cases, everything talks perfectly, everything's happy. There's enough dopamine for the dopamine receptors, and everybody's hunky-dory. When you introduce meth into it, the methamphetamines come in, it triggers the presynaptic nerve terminal to push out a large amount of its feel-good dopamine. So now you have a whole lot of dopamine that's trying to get into those dopamine receptors. And they're like overloaded. They're like, whoa, 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 whoa. The body likes that though. It's getting that effect of that feel-good. So the huge influx of dopamine receptors on the postsynaptic nerve terminal activates all of them, just not a few. And once that's done, it reactivates them. So not only once it taps on there and activates it, it bounces off and keeps trying to reactivate it. And so you get that nice feeling of, I feel great. I want to do that again. And that's where these people start getting addicted to these drugs. So what happens whenever they get addicted to them? Well, we can have increased wakefulness and activity. We've all seen those people that have been on a meth high for several weeks. They've been up for 4 or 5 days. They're not eating. They live off that meth. They may have an increased respiratory rate, rapid heart rate, increased blood pressure, and increased body temperature. That's the big one on that one is the increased body temperature. Their body's overwhelmed. And that's where you need to be the patient advocate and treat that patient, cool them down if they need to be cooled down. So normally the transporters on the presynaptic nerve terminal recycle the excess dopamine. However, with meth and other drugs such as cocaine, they get blocked, and that makes that good feeling last a whole lot longer. And while dopamine was increasing in concentration, you start decreasing serotonin, which that is I feel satisfied. Well, your body's not feeling satisfied, so you're going to eat more cookies. So that's where you start, once your body starts decreasing that serotonin, well, your body's going to start craving, I need more, and I need more, and I need more. And so that's when you start getting these people who are like, they're craving it, their body needs it. They go on those 3-4 day binges and things like that. They can't get enough. The neurons have a limited supply available to them, and it takes a while to rebuild the stores. So they've taken another hit. You have all this meth right in here, but it doesn't have any dopamine or any of the dopamine receptors to work with. And that's why they sit there and just keep taking hits and hits of it, because their body doesn't know not to. It's just craving what they've been giving it to them. Artificially raising the dopamine levels, the neurons do not like massive prolonged fluctuations of receptor activation. Only a few receptors can be activated. So we talked about dopamine being in the body naturally. So is this the cure to sit there and start a dopamine drip on them? Absolutely not. Dopamine, it cannot pass that blood-brain barrier that you give IV. You give somebody dopamine IV, it's not going to go to the brain. So when we look at the amount of people who have a problem and how big of a problem is it, 23% get into a substance or drug program for alcohol, 18% with alcohol and another drug. And so there's a lot of people out there trying to get treatment for this stuff.
All right, I'll just mention a couple things about delirium. So we all see that. What's probably the most difficult part about patients with delirium?
Can't reason with them?
Yeah, that's a good one. Trying to figure out what the heck's going on, right? Maybe they're wandering in the yard, they're not giving you a good history, right? Our history is so paramount about what's going on. But we can get some clues, right? Maybe we can get some family history out of the family there. And that's where it's really important gathering some of that information once you certainly get to the ER, because a lot of what we do in emergency medicine is kind of veterinary medicine, right? Animals don't talk to us. Sometimes patients can't talk to us or give us reliable histories. So delirium's difficult in that. Excited delirium, so one of the reasons there's not an ICD-10 code is because technically it doesn't exist. It's just kind of been what's the term, like a fad term that's kind of been developed for these patients that have what we all in here know as excited delirium, and medicine's really kind of taken that term and run with it. Because it's different than delirium, but what exactly is it? So it's kind of a newer term that's been coined. And I know we all see that. We've talked about meth, certainly the synthetic cannabinoids, illegal weed, the bath salts, whatever we want to call it. Those patients certainly suffer from this. And I think we've got a couple cases we'll go into. One thing about the dopamine, I never thought about it. So you're right, we can't give dopamine IV and get it into the brain, but I wonder if an LP and you give dopamine through the LP needle, what would happen?
We put in protocol.
That's how we used to try to figure things out in the 50s. These days we can't do that. Let's move on to these couple of cases.
We'll try it.
No.
You sign off and we'll try it. All right, so case number 1 here. Approximately 30-year-old male who is disoriented, combative, and requiring at least 4 police officers to hold him down as EMS and fire arrive on scene. So, responded to an assault at a local park with notes in the Navigator program stating assault with LPD on scene and LPD involved. When they put this right here, EMS found 4 LPD officers restraining an unidentified male. That's huge. You need to put as much information in there as possible of how many people was holding this person down, of how many people it takes to hold him down. LPD officers times 4 were controlling the patient. All that's in the subjective chief complaint. That's what they found when they got there. From Lubbock Fire and Rescue, engine dispatched to approximately check welfare, arrived on scene to find PD holding the patient on the ground. EMS was on scene prior. PD said the patient was possibly on drugs, and they were called to the scene because the patient was lying in the mud and taking his clothes off. Well, there's some of your signs.
This isn't Alabama.
Yeah, this isn't. The patient responded to medication. They did a really good report of put exactly what coincides with the EMS report, so that's good. We know it's pretty much the truth. Restraints. LPD officer placed patient in handcuffs prior to EMS arrival with 2 sets of steel handcuffs. It's good that the medic is trying to show how combative this guy is. Assessment upon arrival to the scene, EMS found 4 PD officers securing the identified male in the grass at a local park. Patient is vocal, however, can't understand a word he says. LPD advised they found the patient rolling in the mud and not speaking. So they give him ketamine, 400 milligrams administered IM, 200 milligrams in each thigh. Don't forget, ketamine, when you're giving it IM, it needs to go into the thighs. not the arms, it's got to be the thighs. It needs good muscle mass to work with. Secondary to aggressive and combative behavior with possible excited delirium. The crew member even put that in there. Patient reassessed after ketamine administration. No change in patient condition is noted after administration. So, whatever this guy's on, the ketamine didn't work very well with it. It's not very often that we see that, but occasionally you will.
There's about 5 minutes between that. That was documented, right?
So the crew called UMC. Don't forget that you have that base contact in your interventions. You put EMS advised patient condition that 400 milligrams of ketamine had no effect on the patient's status. Advised to administer 200 milligrams more of ketamine. So we're looking at 600 milligrams of ketamine on this guy now. So he gave 100 in each thigh, secondary to orders. Soft restraints placed on the patient's wrist and ankle, secondary to patient remaining combative after medication administration. Range of motion is present prior to and after application of soft restraints. He placed him on the cardiac monitor, showing sinus tachycardia. Vital signs, 95.7. His temp is cool. Is that unusual for what we've been kind of talking about? It is.
He's in the mud.
Yeah, he's in the mud.
And he didn't have clothes on.
He's naked. Vitals obtained prior to intubation because they didn't intubate this guy. So IV established. They finally got him calmed down enough where they could at least get an IV on him. And they gave him 30 milligrams of etomidate to facilitate intubation. So when you looked at this report through the whole thing, this guy never calmed down. Even after 600 milligrams of ketamine, he never calmed down. Talk to Troutman here just a second about that. 200 sucks, airway clear of saliva and small debris. Remember, we told y'all whenever we put ketamine in there that they're going to salivate, possibly with the ketamine. 600 milligrams of ketamine, that's a whole lot of ketamine. Intubation, 7-point ET pass through patient's vocal cords. Patient remaining combative after, secondary to patient being combative after 2 doses of ketamine. So he documented pretty much why that they intubated this guy. Patient reassessed after paralyzation, sedation, and intubation. Under airway, he put advanced airway in place. That's good. Assisted on the breathing. Is unresponsive. He put why the patient is unresponsive because he's got him paralyzed, and he got him paralyzed right here. They gave him 100 mics of fentanyl and Versed just to keep him sedated. Remember, if we're going to give etomidate sucks, we want to give something to back up that etomidate sucks so that we do not have people that are consciously with it. They gave him 10 milligrams of Versed. And he puts in his narrative, just reiterates the fact that he got a second dose of ketamine and things like that. The hospital outcome on this guy, he was admitted to ICU for meth, intoxication, and remained intubated for the night. He was agitated and reporting muscle soreness, but otherwise his condition was unremarkable. Positive for meth and marijuana.
Kinase, CK, so that's what comes off from muscle breakdown, right? From this guy just being so crazy, essentially. And that's why his muscles were hurting, most likely. And remember, when that's high, you clog up the kidneys, essentially, and put you in renal failure. And 3,000 is really high. And just essentially fluid. Sometimes you give bicarb and try to alkalize the urine. It kind of gets rid of the CK. It's reversible if it's treated.
Yes.
Okay, it's funny because whenever I finally found this patient after searching in the computer system, he, I think it was a week ago or 2 weeks ago, somebody had taken, 1 week, somebody else had taken him in for the same thing. So he's one of those that, he loves those cookies. He's gonna keep eating them cookies. Just a side note, one reason we continue to emphasize detailed documentation of your patient reports, like a tin can, a string, impression and plan, intubated for airway protection after being sedated. You saw what the crew members documented, but this is what the hospital documented, that he was intubated after being sedated. All right, so Troutman, on this one, he'd been given all that ketamine IM.
Right.
Okay. You know, the gold standard is try to give them the ketamine IM. I mean, that's been proven that the IM ketamine works really well. If you could have got him controlled a little bit to the point that you could have started an IV and you got doctor's orders for 200 more of ketamine, would you prefer IV or back in the muscle?
I think that's no preference. It's, you know, like the way we do it currently, if we have an IV, then we give it IV, which I would argue if at that point, if we were safe enough getting an IV, did they need more ketamine? See what I'm saying? Which, you know, because some ways you could say, well, why ever give it IV? But I know we had cases where we showed up, the patient was calm, we got an IV, we started transport, then boom, they turned on us. And that's really why we have that IV there.
Yep.
So the more, what I would have wanted to see to give it IV is, let's say that initial 400 worked, and we got them calm, we started an IV, then halfway to the hospital, they're back up again. Then that's when you'd look at, I think, giving it IV.
Because that's where we've seen where ketamine, when crews say that ketamine doesn't work very well, it seems like when the meth is on board, and it's like their body eats through that ketamine like it's candy. And so, because we've had those calls where they got there, they gave it to them IM, the patient did exactly like what they're supposed to do, but on the way to the hospital, it turned into a fight in the back of the truck. And so, just curious about that, because we are learning about this drug, but the studies have proven that for excited delirium, ketamine works better IM for long term. Which makes obvious sense. So it's always best to give that stuff IM. So what other stimulants are out there? Meth isn't our only concern. We have other ones that we're going to look at. We talk about the synthetics. This one right here, what's that one called?
Donnie's fun.
Chili Willy. Chili Willy. This is the newest package that we have found. Y'all bring it in?
I think so.
It's at 5.
Yeah.
We're getting a pretty good selection. So, you know, there for a while we saw the My Blue, the My Green. Now we got Chili Willy. So we all know this is an issue. You go anywhere around 27th and Q, you can find this stuff. The problem with synthetics is people are starting to buy these synthetics, and y'all have been told this, from China or wherever, and they're getting it here, they're getting the package labels, they're getting all the stuff that they need, and they're going out in their backyard, cutting the grass, letting it dry out, putting it on the table, they're spraying it, putting it in the envelope, selling it for $20. I mean, my operation is going pretty good. I'm proud of it. And you know, even the package, what you get tells you it's not for human consumption. But these people are still taking it. We know this, okay? We've seen some pretty odd things here in Lubbock, I would say, on people doing the synthetics. There for a while, it kind of died down, and then it picked back up. About the time that we think that it's calmed down, we go on 10, 15 people a day. You know, there's been a whole lot of questions about, you know, well, they got up and, you know, ran away from you. And if someone is standing there, and this is where I want everybody to be kind of careful about. If somebody is standing there and said, yeah, they were doing synthetics, I was sitting there doing it, they asked me to do it, and I said no, and they got up and left. You know, to be honest with you, I would probably document that as a refusal. There's not a whole lot of documentation there. Patient refused to sign, patient jumped up and left, because if you clear it on an N6 or an N1, it could land you into some hot water. And I feel that be careful. Patient refused everything. They just got up and left. Patient refused to sign. It's not much more documentation. It protects you in the long run. And we have a lot of these people doing this. So it's similar to marijuana, which is the real stuff. How is it similar? Well, the cannabis, it's got the THC, and back when everybody was trying to invent a new drug to kill pain for cancer patients is when they started coming up with this, and they realized that they messed up, they made some bad stuff, and so that's why they put skull and crossbones on it, and you know, it's not for human consumption, but people still do it. However, just like the reward pathway with meth and dopamine, the receptors will draw back and drug tolerance develops with repeated use. So it's similar to what happens with the meth. THC in cannabis is partial agonist, where the synthetics is a full. Some of the adverse effects, you get panic attacks, suicidal ideations, hallucinations, they get paranoid, aggressive. We've all seen the aggressive side of it. We see that every day on Avenue Q. Tachycardia, hypertension. Getting close on time, so when everybody's... Here's a video. He just got finished taking, some of y'all might have seen this. We thought it was pretty interesting. He just got finished taking some synthetic. That's his buddy right there. Says, man, this has got to be some cool stuff. We only paid $10 for it. So I'm going to take a hit too. We have the music playing, because if anybody has seen this online, there's a lot of bad language. And that's what we were talking about. When you look, when he was sitting there, he has that Gatorade bottle. But where did the red vomit come from? Whether he, is it blood or did he eat something red earlier? I don't know. And that's what's crazy is these people are, this stuff is all over the YouTube and stuff, and people see this, but yet they still do it. Bath salts. There for a while we saw bath salts quite a bit. I don't know if anybody that's ran on any bath salts here lately. It's real similar to cocaine and meth. Same concept, triggers the dopamine release. That's how they kind of get that feel good. I'm happy. I want some more of it. I like the cookies, and so that's where they want more and more of it. Cathinone is a stimulant alkaloid found in the leaves of the cot plant. They eat the leaves and stuff, and that's chew it. Kim was saying that in some countries, most of the countries, this plant is illegal, but in some countries they chill out and talk with friends and chew on a leaf. This is a bundle. Some people, she's found that some people even put this in their freezer to preserve it. Bath salts, similar to ecstasy and things like that. 3 or 4 of them, common synthetic cathinone, affects the brain in a manner similar to cocaine, but 10 times more powerful. So bath salts are a lot more powerful than cocaine and things like that, and that's where we see these people. There for a while when they were kind of big. It was funny because you just kind of saw them. They were like just looking in a dazed, catatonic state, and just like I had one officer that looked at a patient and he went and booed to her and said he was the devil. I thought, oh dear God, I hope she don't remember this. It was the officer, not me. We've all heard Flakka, gravel. That one's talking about how it sets the blood on fire. A lot of people got addicted to this and they realized how bad it actually was. And a lot of people were dying from this stuff. We're fixing to watch a video of a guy that talks about how he got on Flakka and took a lot of Flakka and finally got out off of it. It's like meth, targets the brain's reward pathway with the dopamine, just like the methamphetamines does. And so that's why when they get on, they want that feel good. I want more, I want more, I want some more of those cookies.
When people get high, it can get scary. Some run through the streets naked. Others climb fences and get seriously injured. One man seen here trying to break into a police station.
People think that they're being chased, they're being shot at, the devil is chasing them.
I have a sitter. I must make amends for all the wrongdoing I've done.
This right here is for Flakka, alpha PVP. It's so cheap, the dose is going for as little as $3 a hit.
This is probably the worst and the fastest drug that I've seen catch on, and it's probably the most dangerous that I've seen.
What were you like on Flakka?
I thought I was somebody I wasn't. If I wasn't the gangster Al Capone, then I was a porn star. So you begin to see that you're not who you think you are, you're just in your own world. No coming back from it if you don't want to. So I think I tried to stop probably month 8. Failed every time.
He finally decided to get help and entered a drug treatment program.
All right, so we're going to talk about restraints real quick. When we talked about this, somebody wanted to talk a little bit about restraints. In the protocol, we kind of talk about the verbal de-escalation, not making things worse. Don't make them mad. Don't ag it on. You want to try to calm the situation. Physical restraint, one person on each extremity. Knee to the chest, not a good practice.
Don't do that.
Don't do that.
This is how people die.
No.
For what to do.
No. Prolonged prone position, no. Like I said, I know tensions get high when we run on this same person over and over and over again. But remember, they're still a person. And I would really hate for our service to be marked as a service that has a lawsuit against it for, hurting somebody when they were on synthetics, breaking their arm or, something. There's no need for that, honestly.
And certainly these 3, if somebody dies from that, you're going to lose your license and the service will be sued. There's no excuse for it.
Chemical restraint performed quickly to prevent injury and prolonged tachycardia and hypothermia. As you saw in the video, the guys running down the street naked. If you restrain somebody with soft restraints, what do we use? Not Curlex. Soft restraints. That's what we use. We don't use Curlex. Curlex is not intended as a soft restraint, and my opinion about it is if you use anything other than the packaged soft restraints and something happens to that patient, you're probably going to be held liable for it, because that's not what we're supposed to use. So remember that. Case number 2, 100-kilogram guy in his late 30s, brother called EMS because he was not acting right. We hear that a lot. Patient has a history of drug abuse, particularly with meth. Has history of GI bleeding. Patient states he is supposed to be on protonics. Denied by family members. Responded to a report of an unknown problem with dispatch advising caller stating his brother was not acting right. Upon EMS route, found history of meth use. The patient presents with extreme agitation, denying drug use. Patient agreed to go to the hospital, started screaming profanities at EMS attendant stating that he needed his protonics. I guess the stomach was hurting. Patient presents with inability to complete thoughts and sentences, seemingly involuntary arm and hand movement. So, I mean, the crew did a really good job. They did what they put in the report, what they were told when they got there. Okay, the family told, his brother told him all the information that he had. His airways patent, normal respirations, large pulse place time, cardiac monitor, patient placed on the ECG monitor for ectopy and dysrhythmia, secondary pending ketamine administration. So ketamine, 200 milligrams administered to each thigh, secondary to patient presenting with signs of excited delirium from an unknown etiology, show minimal signs of relaxation and relief. His vitals, 178/94, 403, 94% N-titles. Remember, N-titles are a must when you give somebody ketamine, whether it's for pain management, excited delirium, or what. You give ketamine, you need to have them on N-titles. I'll give you a good example why in just a second.
I think I want to mention here, this case we mentioned there's extreme agitation, and the last case we had four officers. Just remember to try to really back things up. Just occasionally we get scrutinized by the hospitals on our ketamine use, and that last chart, I think you can show that to anybody. It's very obvious that patient needed extreme measures, right? This one, I think when you first look at it, you wonder, well, was that the right call? I think as we go forward in the chart, it looks better, but we know from the get-go there was probably 4 people trying to hold this guy down, and we shortened that to extreme agitation. So just remember, put that in there.
After they gave the initial dose, they called via radio for possible orders. EMS relayed patient info and advised that more sedation was potentially needed for crew and staff safety. Personally, crew and patient safety. Put that patient safety is in there as well. So, medication request for safety of crew and staff receiving hospital. Doctor advised EMS to administer no more medication. Transport patient to the hospital. EMS confirmed the orders. So, do what he's supposed to. Restraints. Patient was extremely combative and aggressive with EMS. Patient began swinging his arms violently. EMS secured both arms at the wrist with soft restraints. So, like Troutman said, the further you get into the report, you kind of see how this progressed. Restless and extremely agitated, threatening EMS personnel. I am not going to repeat what this guy told the crew member. It was not nice. Wasn't Troutman? Not nice at all. Still have him on N-titles. Patient moved, secured 2 straps. One thing I know that helps out is patient moved to cot. How do they move to the cot? Did you pick them up and move them to the stretcher? Did you put a mega mover under them and move them to the stretcher? Did you put a sheet? Explain how you move people to the stretcher. That helps out. Patient was taken to EC number 17. He was intubated in the emergency department about 12 minutes after arrival and admitted to the MICU. Extubated the next day, required sedation due to agitation. It's really similar to our last guy. Meth, barbiturates, and benzes. Negative alcohol. His pH was 7.2. Is that an issue? Slightly, just a little bit. Upper GI bleed, methamphetamine, MICU documentation with unknown past medical history presents to EC due to combative and confusion. The patient has prominent history of amphetamine abuse with history of multiple EC visits related to complication of abusing meth, including chest pain. Yeah, where he shot his meth. And I won't go read that.
Wow.
He was intubated, sedated, there's no family by bedside. Lavage was not attempted. The patient has dark black contents from his NG. Will discharge today. He does not want to follow up the appointment. Imagine that. But he has no intention or desire to quit. Right there, the patient even said that he has no desire to quit. That's why we love him so much.
So these two cases are relatively similar, right? I mean, they almost could be the same patient.
Yes.
Are they the same patient?
No.
No. Okay. So we really have tried to minimize you guys having to call online med control. You like that where you don't have to call. Is that correct? Yeah. I think it's important for us, or for me certainly, to give you the tools that you need to take care of patients. And truthfully, when this guy's running around swinging at people, that's not the time to be trying to call med control. And we've got two very different answers on this, right? And it's going to depend on who you talk to, which doctor you get. Some folks think the ketamine is great, others think that it's terrible that we give it. So we obviously think that it's great. So whenever I see that, one of the big questions I ask is, well, are we given the right tools? We kind of have worried about this synergistic effect that maybe happens with multiple doses, but maybe that's wrong. Maybe it's not a huge deal. So there's actually, these are two fresh studies, like April 16, I think May of 16. And let me see, I have to read this again. So, well, this first one was just kind of more of an FYI. They compared ketamine to Haldol, because there's, like I said, there's still some folks say, why do you guys use ketamine? There's other better drugs like Haldol or Versed that you could be using. But in this study, ketamine was superior. What's interesting though, ketamine is associated with more complications and a higher intubation rate. But if you go in and read, and tell me if I'm right, Kim, all those intubations were done in the ER, right? None of them were done pre-hospital. And so then you ask yourself, well, why was that? What I think it was, and I think that the author mentioned too, ketamine even, and I'm on the younger side when I've been out of residency now 6-7 years, we didn't use ketamine in residency. It was a bad drug. That was a drug people used 30 years ago, and vets used it for horses. But now it's kind of this resurgence. And when you walk in and see a patient that you've given an adequate dose of ketamine, what do they look like? They look like they need an airway, right? But if you think about the medication, they are technically protecting their airway. So I think that's probably a hair trigger of some emergency physicians dropping a tube. And hey, we all like to drop tubes, right? So then on the second one, where this one used the synergistic effect of, I don't think they're all listed here. It was Curadol, Versed, Ativan. It more or less used all these different medications at various times and then ultimately used some ketamine with them and essentially found that it was relatively safe to do and actually help sedate the patient. So I think we're going to look at, do we need to maybe allow or have repeat doses be just protocolized and not have to be calling in for med control? Would y'all like that? Do y'all think that's a good idea?
Absolutely.
Cool. I think that's all I have. Any questions for me?
I think it'd be good.
Yeah.
All right, so let's look at the report of the month. We look at a lot of reports, and we're proud to be able to do this for people. Dispatch for Category 31, Delta 2. Male in his 30s was found by his mother unresponsive, lying in the prone position on the floor. She called 911, approximately 150 kilograms. She did a nice job on patient's mother stated that she found her son. She put in the chief complaint what was told by the mother. The patient is unresponsive, so of course they're not saying their chief complaint, but the mother does. History, hypertension, cirrhosis, and no allergies. Whole list of medications right here. Notice that one right there. Patient found lying on the floor, prone, unconscious, carrying jaundice.
What was the man done?
Hydrocodone.
Okay.
Normal respirations, unresponsive. A contusion noted to the left hip and no other trauma noted. So we got a contusion. They put right here, pelvis, contusion of unknown age noted to the left hip. So please be descriptive in your body survey. Be as descriptive as you can. It helps out tremendously. Blood pressure 152/98, 103, 14 and fatigued. Blood sugar is 179 with a GCS of 3. 98.1. Place the patient on oxygen, cardiac monitor, 12 lead. Normal respirations, they're a little bit normal here. Color jaundice. They gave, if right here you look, pupils, the left of 4, the right of 5. You know, yes, we may be dealing with something upstairs, but we don't know yet. Upon arrival, found unconscious, lying prone on the floor with his head slightly turned to the left. I did go wrong. Laying on a pillow with drool noted in the pillow. Light blood tinge and drool. Okay, right here. Oxycodone was filled on with a quantity of 60 pills, had 8 left. Okay, so we find this guy lying on the floor with all this oxycodone missing. Is it a possible overdose? Yes, possible. We don't know for a fact. So we give the patient 0.5 of Narcan, which is the correct dose, especially so we don't put him into withdrawals, if that's what it is. The crew did get a little bit of response out of the patient whenever they gave him that, so the crew kind of thought, well, maybe this is an overdose. So they kind of went with that. When they got him to the hospital, here's his CT. Looks good, looks good, looks good. Oh, yeah, something there.
So everybody sees what we're looking at. I mean, obviously this is blood, and then the big thing, stop it.
Yeah.
You look for midline shift, so if you kind of, you notice this ventricle's gone because it's pushed against, that's where you start to get problems with the increased ICP. Because you see you've got a couple centimeters, well, 1.7 centimeters of blood. A comment or, what's the next slide? I'll just make a comment or two. When I first looked at this, the report of the month, I kind of looked at this and, you know, and I hate armchair quarterbacking, and I know that's very difficult for all of us when we look back at this. When I first looked at this, I'm like, what the heck? This guy's a GCS of 3, huge head bleed. Why did we not intubate this patient? We were mucking around with Narcan. This doesn't seem like a report of the month. But when you stand back and look at it, there's no obvious trauma. There was maybe some ecchymosis, you know, on the thigh, no big deal. Nothing on the head. Or jaundice, you know, liver disease. They've got a box of 60 Norco, and almost all those are missing. So when you stand back, you say, actually, this guy, whoever treated this patient, they were spot on. You know, when we look at it after the fact, we can see things, but I think when you remove yourself and say, okay, if I was there from the get-go, I think everything looked done very appropriately and very astute. Oh yeah, and so why did this patient bleed? So the jaundice probably had liver problem, right? What does that do to you? What's that do to your blood? It makes it where you don't clot as well, right? So their INR, that's a measure of how thin your blood is. It was very high. So we don't know if this was related to trauma, but this very well could have just been a spontaneous bleed, or it could have been just as simple as falling out of a chair. This is essentially like a patient on Coumadin with a high INR, and they bled from that. But
Remember, this guy was 30 years old. So
yeah, what do we figure? He's 25 days younger than I am. Was. Yeah.
You're ahead of him now.
Yeah.
He did die 2 days later in the MICU. So, you know, not good. That was Dakota. She got report of the month. She did a great report, I felt. She's done a really good job for us.